I invite Dr. Arshia Fatima, MBBS MD, consultant biochemist, Bizia Maria Hospital, Hyderabad. The topic is reproductive hormones in premature ovary failure. Arshia worked as a senior resident though Osamiya Medical College. She is laboratory head and full-time consultant biochemist since 2018 at Bizia Maria Hospital, Hyderabad. She leads a team of almost 20 laboratory professionals to ensure the affinity and timely diagnostic service. She has developed, implemented laboratory policy and procedure to improve the workflow. And a lot of research paper of published for the Dr. Arshia Fatima. Thank you.
Okay,
Thank you.
Good morning, everyone. I would like to first of all thank the Mindray team and the organizers, especially Shama and Mr. Farid, who had been invited me to be a speaker today and given me this opportunity. Today I'm here to talk about reproductive hormones in premature ovarian insufficiency. Actually, I wanted to talk whole about the reproductive hormones, but because of the limited time given to me, I have concised my topic to discuss about the role of the reproductive hormones in premature ovarian insufficiency. I feel this topic is important because to understand the normal aspects of the reproductive hormones and also the abnormal aspects and their interpretation in the result format. Okay, so first of all, I'll be discussing about a case study which I have come across in my hospital, and then I'll be discussing the normal aspects of these reproductive hormones and the abnormal changes, what we'll see in the premature ovarian failure. Okay, let's get started. So I have come across a case study. A 25-year-old female patient has come with the complaints of irregular menstrual cycles since 7 years and amenorrhea since 1 year. She's married since 8 years and she's an early gravida. She has had her menarche since the age of 12 years. There is no history of acne, hirsutism, and so on. There is history of treatment of usage of OCPs some time back, but not presently. And there was no significant past history, and on general examination also she was quite normal. The investigations which were advised was the routine investigations, which included CBP, RBS, CUE, and then the thyroid profile and hormonal profile and ultrasonography pelvis. So we have done the UPT test was negative, CBP, RBS and all was normal. Thyroid profile was also normal, and ultrasonography pelvis showed some poor follicular count in both the ovaries, and the hormonal profile included FSH, LH, prolactin, estradiol and AMH tests. So these were the results which I could see in my lab. So we have done in VIDAS with the principle of alpha. So we can see the FSH is 108.54, quite increased. LH is also 28.75, this is also increased. Prolactin is normal. Estradiol, we could see a lowered value of 13.99. And her AMH was totally negligible and undetectable, that is less than 0.01. So to interpret these results, I'll first discuss briefly about the normal aspects of these reproductive hormones, and then we'll go into the interpretation of this result. So FSH and LH, usually these reproductive hormones have different phases in the menstrual cycle. A normal female has in the menstrual cycle, has two phases of follicular and the luteal phase. It is divided by the day of ovulation. The first 14 days is the follicular phase, and the next 14 days are the luteal phase. So the follicular stimulating hormone, it rises in the early follicular phase, and then it remains elevated and then goes down during the luteal phase, while the LH, it rises during the early follicular phase, and then it begins to rise in the mid-follicular phase, like as you can see in this graph. Before ovulation or before the ovulation day, like around 10 to 14 hours before the ovulation, we can see a mid-cycle surge of FSH and LH, and then it goes down to normal levels in the luteal phase. It happens in every menstruating woman. So by this we can understand the normal ranges of FSH and LH. In the follicular phase of the menstrual cycle, we can see the normal levels of FSH as till it comes to 9.9, but when the patient has the mid-cycle surge, the values go till 17.2 for FSH, and then LH surge is more than FSH, so the LH values in the mid-cycle surge go till 60 international units per liter, and in the luteal phase, it again goes back to normal levels to 9, and in LH 16. So these are the normal levels, but you can see in the postmenopausal females, when the patient has stopped menstruating, we have seen the high values of FSH and LH. This can be due to overaging. The follicles become resistant to the gonadotropin stimulation, and the circulating FSH and LH levels rise. So we can see here, as the ovaries stop responding, like there is no secretion of estradiol levels goes on decreasing, and by this there is this overstimulation and the negative feedback, due to which the FSH and LH levels rise after menopause. So you can also see for detecting along with FSH and LH, even estradiol determinations are being done. Estradiol is the major form of estrogen secreted by ovaries due to the stimulation by FSH. In order to determine hypogonadism, this is always done along with FSH and LH. So we can see the changes in estradiol levels in a normal female. As you can see in the early starting days, the estradiol levels are less than almost 100. And again, it rises to a peak of 100 till 500 picogram per ml before the ovulation day, and again it comes down, it drops precipitously, and then it rises again in the luteal phase till 200 picogram per ml. So these are the normal ranges of estradiol that can be explained in this way. And in menopause, again, the estradiol levels goes back to less than 58 per picogram per ml. This is again explained by the depletion of follicles in the ovaries after menopause and no secretion of estradiol. So by this, we can interpret our case study, like FSH is increased, LH is increased, and estradiol is decreased in this patient. So by this hormonal assay, we can help in the differential diagnosis of amenorrhea in this patient. As we can see, amenorrhea is caused by hypothalamic causes, pituitary causes, ovarian causes, or uterine causes. If it is hypothalamic and pituitary causes, FSH and LH gets decreased, and estradiol is also decreased. But when it is uterine causes, it can be due to the adhesions or some Asherman syndrome, where the FSH, LH, and estradiol all are normal. There is no, because the hypothalamic pituitary ovarian axis is not at all disturbed, and due to the adhesions in the uterus, there is no menstruation. But when it comes to ovarian causes, there is hypogonadism due to the ovarian failure. It can be premature ovarian failure, or it can be due to some insult to the ovary due to some surgeries or chemotherapy or radiotherapy, due to which the ovary cannot secrete the estradiol. Estradiol will be lowered in amounts, and due to this negative feedback, FSH and LH gets increased. So by this interpretation, we can do the differential diagnosis of amenorrhea, and we can come to some conclusion. So AMH is also very markedly undetectable amount, so I would like to discuss a few slides about AMH. AMH is also called as Mullerian inhibiting substance. It is an anti-Mullerian hormone. It is promoted as a marker of ovarian reserve. So its concentration decreases with age. So it is considered as a very good marker for fertility decline. So it is actually secreted by the pre-enteral follicles when the follicles are less than 4 millimeter in size, and when the follicle size grows to greater than 8 millimeter, the concentration doesn't happen, the secretion doesn't happen for AMH. Actually, AMH is considered advantageous over the FSH and LH markers, because FSH and LH goes on changing depending upon the days of the cycle. As we usually, FSH is done on day 2 or day 3 of the cycle, and LH done on day 6. But AMH is same throughout the cycle, so AMH is more advantageous compared to the other hormones. So in premature ovarian failure, AMH is totally decreased or totally undetectable due to the low number of follicles or totally nil follicles in these patients. But in case of polycystic ovarian syndrome, we can see high levels of AMH due to excessive number of follicles in these patients. So, AMH advantages over the other ovarian reserve tests because it is not cycle dependent, and the clinical applications of AMH also, we can also see the response of any assisted reproductive technology in other patients, and by assessing AMH in these patients. So the normal values, as you can see, it is age-wise, it is changing. So as you can see, with the increasing age, AMH levels goes on decreasing. Okay. So these hormonal assays help in the provisional diagnosis of this patient. So in this case, the elevated follicle stimulating hormone levels greater than 40 international units per liter on 2 separate occasions, like not just one FSH level, but FSH levels should be done on 2 occasions, and that should be separated by 1 month apart, and that should be elevated, like it should be greater than 40 international units per liter. Estradiol should be less, almost less than 50 picogram per ml, markedly low and undetectable levels of AMH, low enteral follicle counts in pelvic ultrasound, and amenorrhea for 4 months, and patient's age should be less than 40 years. So a diagnosis of premature ovarian failure is established in this patient. So briefly, premature ovarian failure. So it is a condition wherein there is depletion or dysfunction of ovarian follicles with cessation of menses before the age of 40 years. The causes can be idiopathic, which is the most common cause. It can also be genetic causes like the Turner syndrome or Mosaic-Turner. It can be Fragile X syndrome, or it can be induced due to, if at all the patient has undergone any oophorectomy surgeries or undergone any chemotherapy or radiotherapy treatments. So due to the pathological conditions, there is depletion or reduction of follicle number in these patients, which causes the reduced number of circulating estradiol and elevated FSH and LH. So the diagnosis of these premature ovarian failure patients is done by just excluding the pregnancy first of all, and then doing the hormonal assays of FSH and estradiol and anti-Mullerian hormone. And once the diagnosis is established, karyotyping is also done to evaluate the genetic etiology, whether it is a Fragile X or any Turner or something else. And that's it. So in this way, we can understand that how the hormonal assays are helping in the provisional diagnosis and the differential diagnosis of patients. Yeah, that's it. These are the references from where I have done my study. Okay, thank you for your attention.
Hello. Thank you, Dr. Arsia. Nice presentation. Any questions from the audience?